Welcome to episode 22 of the Pro PA podcast. I'm your host, Prof. G. Today, we're diving into one of the most critical and high-yield topics in both clinical practice and panceprep, pulmonary embolism, or PE. A pulmonary embolism can be life-threatening if not recognized and treated properly. In this episode, we'll cover the basics, risk factors, clinical presentation, diagnosis, management, and as always, we'll finish with vignette-style questions to test your knowledge. Let's get started. First, let's look into the kinder patho. What is a pulmonary embolism? Pulmonary embolism occurs when a thrombus, usually originating from a deep vein in the lower leg, travels through the bloodstream and obstructs a pulmonary artery. This obstruction disrupts blood flow to the lungs, leading to hypoxia and increased pulmonary vascular resistance. In severe cases, it can result in right heart strain and cardiovascular collapse. What are some of the risk factors for pulmonary embolism? Well, think of Virchow's Triad, the classic predisposing factors for thrombosis. We have 1, hypercoagulability, 2, venous stasis, and 3, endothelial injury. As far as hypercoagulability, we can think of conditions like cancer, pregnancy, oral contraceptive use, and genetic conditions like factor V Leiden. For venous stasis, we're thinking about prolonged immobility like post-surgery, long flights, or even heart failure. And for endothelial injury, we're thinking about trauma, surgery, or indwelling catheters. The key risk groups, as we just mentioned, based on that Virchow's Triad would be recent surgery or trauma, immobilized patients, which would include long-distance travel or hospitalized patients, any cancer patients or those on chemotherapy, and patients who are pregnant or postpartum. So how do these patients typically present? Well, there is a classic triad, but they're rarely all present, although textbook-wise it is a classic triad of dyspnea, pleuritic chest pain, and hemoptysis. And dyspnea is going to be the most common symptom that we see in a PE. Other symptoms might include tachypnea and tachycardia, hypoxemia, which would be like a desaturation on pulse oximetry, or even syncope in a massive PE. Physical exam findings, they may be pretty nonspecific, but they can include tachycardia, hypotension, and signs of right heart strain like JVD or right ventricular heave. You can also notice on the lower leg, you might notice some unilateral leg swelling or redness if a DVT is present. So I think as far as diagnosis, it's really important to understand how we diagnose a pulmonary embolism. And there are some risk stratification tools that we use. The first one I want to mention is the Wells criteria. Now, the Wells criteria is going to predict the probability of a PE, and it's going to place patients in either a low risk category, a moderate risk category, or a high risk category. And there is a Wells criteria and a modified Wells criteria. You can use either of the two. And you're going to look for these risk factors that will give them points. And the higher the Wells score, the more probability the patient has of having a PE. So some of those criteria include clinical signs and symptoms of a DVT, alternative diagnosis less likely than a PE, heart rate greater than 100, immobilization for at least 3 days or surgery in the past 4 weeks, a previous diagnosis of a PE or DVT, hemoptysis, or malignancy with treatment within 6 months, or palliative. And so those are the criteria. Each one of them has some associated points, and you rack up that tally and you'll be able to tell whether a patient is at low, moderate, or high risk. We generally think of patients greater than around 4 to 6 points as being high risk, and those patients you're going to want to start with imaging. And the imaging of choice for a PE is going to be a CT pulmonary angiography, or CTPA. Now, for the lower risk patients where PE is not your top diagnosis and they have kind of a low risk, but you're considering it, you would consider ordering a D-dimer blood test to rule them out. Another way that we can rule out patients, and a way that I use pretty often in the emergency department, is the PERC rule, PERC, which is the pulmonary embolism rule out criteria. And this is used to rule out PE in low-risk patients without need for further testing. So if I did a D-dimer on every patient that came in with shortness of breath and chest pain, I'd be doing a lot of unnecessary D-dimers. So I use the PERC criteria to help me rule out those patients and say it is not PE based on the PERC criteria. And a mnemonic that I use for this PERC criteria is HAD CLOTS, HADCLOTS. And I'll go through each letter now to help you out, okay? So H stands for hormone use, like oral contraceptives or pregnancy. A, age greater than 50. D, DVT or PE history. C, coughing up blood, hemoptysis. L, leg swelling, unilateral. O, oxygen saturation less than 95. T, tachycardia, so a heart rate greater than 100. Or S, surgery or trauma within the past 4 weeks. Now, it's important to note that if all of these PERC criteria, and that's a lot of criteria, if they are all negative and the patient is low risk, you can rule out a PE without any further testing. However, if even one of the HAD CLOTS criteria or the PERC criteria is abnormal, you cannot rule them out via PERC criteria, and you have to consider whether to start with a D-dimer or a CTPA based on how risky this patient is. So we just mentioned a few tests. I want to go in a little bit further depth about them. The D-dimer is a blood test that we can do on patients. And remember, it is sensitive, but not specific. So a negative D-dimer can rule out a PE in a low-risk patient. But a positive D-dimer means we have to do more studies on that patient. So imaging that we like to do, the gold standard for diagnosis of a pulmonary embolism is going to be a CTPA or a CT pulmonary angiography. Another test that we can do from an imaging standpoint is a VQ scan. And this is an alternative for patients who cannot undergo a CT. For instance, they might be pregnant or they might have a contrast allergy. So that's another option that we can use. Other testing that we might do on these patients, an EKG. So this might show an S1Q3T3 pattern. This is very specific for a PE, but it's pretty rare to see that. More commonly, what we'll see on an EKG is changes like sinus tachycardia. An echocardiogram we can do as well. It's going to show maybe some right ventricular strain if it's a massive PE. And you can also consider doing lower extremity Doppler ultrasounds to look for DVTs if this is suspected. Many of these PE patients also end up getting a chest x-ray, and although this is more book med than street med, they can show some nonspecific abnormalities on chest x-ray that sometimes you will be tested on, two of which I would like to mention here. So one is Hampton's hump, which is basically a pleural-based wedge infarct. And you can kind of see this little hump on the chest x-ray. The second thing that they might mention is a Westermarck sign, which is a vascular cutoff sign on chest x-ray. So keep an eye out for those in your vignette style questions. Much less likely to see those things in clinical practice. All right, so how do we manage PEs? So anticoagulation is the mainstay of treatment for pulmonary embolism. We need to start immediately if a PE is suspected, even if you have not confirmed it with an imaging study or a D-dimer or whatever. Start the anticoagulation if there is no contraindication. So for these patients, they often get either an unfractionated heparin, a low molecular weight heparin, or some of the more recent oral anticoagulants, and these are for more stable patients. Now, if a patient is unstable or crashing or is a very massive PE, we can consider thrombolysis. And this is, again, indicated only in massive PEs with hemodynamic instability. And we often use the TPA. Supportive care, we're going to want to use with our patients as well, including oxygen, IV fluids for hypotension, and inotropes if needed. And we also have, as a last-ditch effort, surgical or interventional options. We can do an embolectomy for unstable patients when the thrombolysis is contraindicated. And last but not least, we can offer the patient an inferior vena cava filter or IVC filter. And these are also for patients with contraindications to anticoagulation. Let's look at some quick clinical pearls. So, one, an unexplained tachycardia or hypoxemia should always prompt consideration of a PE. Remember, if you're not thinking that PE is on your differential, you're never going to make that diagnosis. And PE is a diagnosis that you absolutely cannot miss. So, it should always be on your differential for those patients who are tachycardic and hypoxemic. Tachycardia is actually the most common symptom associated with PE. Number two, a D-dimer is great for ruling out a PE in low-risk patients, but shouldn't be ordered in high-risk patients. Just go straight to the imaging. And you can use that Wells criteria or modified Wells criteria to help you decide if this patient is high risk. Number three, use PERC criteria with the had CLOTS mnemonic to safely avoid overtesting in the low-risk population. Number four, a massive PE, we're seeing hypotension or even shock, and we're going to treat with thrombolysis or even an embolectomy. All right, now that we've gone through that quick crash course, let's test our knowledge. So we have a 60-year-old female with a history of breast cancer who presents with sudden onset dyspnea and pleuritic chest pain. Vital signs show tachycardia and an oxygen saturation of 88% on room air. Chest CT angiography confirms APE. What is the best initial treatment? Is it A, start aspirin therapy, B, administer thrombolytics, C, start low molecular weight heparin, or D, perform an embolectomy? I'll give you a few seconds to think about it. If you said C, start low molecular weight heparin, you are correct. Remember, anticoagulation with low molecular weight heparin is the first line treatment for stable patients with the PE, particularly in cancer-associated thrombosis. Question 2. A 35-year-old woman presents with sudden onset of dyspnea after a long haul flight. Her Wells score is a 6 and she is found to have tachycardia. What is the next best step? Is it A, order a D-dimer test, B, obtain a CT pulmonary angiography, C, perform a VQ scan, or D, start empiric anticoagulation? I'll give you a few seconds. If you said B, obtain a CT pulmonary angiography, you are correct. Remember, a Wells score of greater than 4 indicates high probability of PE, and imaging is the next step for confirmation. All right, I want to thank you for joining me on this episode of the Pro PA podcast on one of the most life-threatening and high-yield topics in medicine. I hope this episode clarified how to recognize, diagnose, and manage a PE with confidence. If you want to look a little deeper into these type of conditions, check out my pulmonary module playlist on my YouTube channel, Prof GPAC. And stay tuned for the next episode in the pulmonary circulation series, where we'll cover pulmonary edema, including its causes, presentation, and management strategies. If you found this episode helpful, don't forget to follow the podcast and turn on notifications so you never miss a new episode. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.